Good afternoon all. Yesterday we have seen the genito-vaginal fistulas, how it occurs and what is the etiology, that all factors we have seen. Then coming to the vesico-vaginal fistula. It is the commonest type of the fistula we have seen. So the vesico-vaginal fistula, you can see the vesico-vaginal fistula. Here the vagina, the bladder, there will be the abnormal opening will be there. Okay. Vesico-vaginal is abnormal communication between the bladder and the vagina, and urine escapes into the vagina, resulting in true incontinence. How in vesico-vaginal fistula, the urine passes through the vagina. That is the abnormal opening we can see. So, abnormal communication between the vagina and the bladder. Okay. Then historical perspective. The first recorded of VV vesico-vaginal fistula is found in writings of ancient Hindu medicine, Vedas and Upadevas. These all things no need a study for your awareness only. I am mentioning this one. Just you read. That is how it is. So no need of explaining here. Predisposing factors: history of pelvic irradiation, cesarean section, endometriosis, prior pelvic surgery, pelvic inflammatory disease, diabetes mellitus, concurrent infection, vasculopathies, tobacco abuse. In classification of vesico-vaginal fistula, it can be classified from simple and complicated. Simple means fistula is less than 2 to 3 centimeter. In complicated means it is greater than 3 centimeter in size. Supratriagonal, near the cuff. Fistula distant from the cuff or has triagonal involved. Then history of radiation or pelvic malignancy. History of previous radiotherapy and pelvic malignancy is present. Vaginal length is normal, vaginal length is shortened and associated with scarring. Health issue involving urethra, vesical neck, then ureter, intestinal fistula, good access, previous unsuccessful attempted repairs. In classification according to the site of the fistula: high fistula, juxta-cervical, mid-vaginal fistula, low fistula. In high fistula, it's two types: juxta-cervical and vault. Vesico-urethral, uterine. Then low fistula is bladder neck, urethral impact. Then urethral involvement, segmental, partial bladder neck loss, complete bladder neck loss, circumferential fistula. Urethrovaginal fistula, a small fistula below the bladder neck, is incompetent. Massive vaginal fistula encompasses all three levels and often includes one or both ureters in addition. Classification according to the size: has seen small less than 20 cm, 2 to 3 cm, large extensive. See the figure. Evaluation of vesico-vaginal: history, general and genital examination, confirmation diagnosis, radiological evaluation, cystoscopic evaluation. History: presented continuous escape of urine per vagina, true in classical symptom. Then patient got no urge to urine. Small fistula escape in urine occur in certain position and can also pass urine normally. Leakage of urine following surgical injury occurs from the first postoperative day. Obstetrical fistula symptoms take 7 to 14 days to appear. Urethral fistula situated high up may present with stress incontinence. Vesico-cervical and vesico-uterine fistula may hold urine at the level of uterine isthmus and remain continent. Menorrhea, clinical hematuria at the time of menstruation is present. Pruritus, vulva pruritus will be a perineal skin irritation, fungal infection due to constant wetness. History, age and socioeconomic status of women. Previous gynecological surgery, radiotherapy, previous history of prolonged labor, trauma, childbirth. Then how the trauma childbirth that occurs, previous delivery, suspected cause, detailed obstetrics history should be gathered, time of occurrence, history of urine leakage, timing of leakage, amount of leakage, voiding per urethra apart from the leakage, any leakage of feces, gas leakage, any attempt of previous urethra, previous repair of fistula. An examination, general examination, perabdominal examination, surgical scars, vulval inspection, that is escape of watery discharge per vagina of an ammoniacal smell is characteristic. Sodden or excretion of the vulval skin, varying degree of perineal tears may present. Per speculum examination, Sims position and Sims speculum. Unit pooling of fluid in the vagina, situs, size, number of fistula, assess quality of surrounding tissue, tissue mobility, bladder mucosa may be visibly prolapsed through a big fistula. Then tiny fistula is evidenced by puckered area of the vaginal mucosa. This is the Sims speculum, the device which will be inserted into the vagina to visualize the vagina and the surrounding areas. This is Sims speculum. Another one speculum is also there, Cuscus speculum. That means then that speculum, it's no need of any assistance. Then woman cups while lying in the Sims position. This is the Sims position, and bubbles are seen coming through the tiny fistula. That per vaginal examination, palpate anterior and posterior vaginal wall, gives better idea of fistula. Assess the tissue, assessment of tissue, mobility, size, site, determination of the degree of tissue, inflammation, edema and infection. Confirmation of diagnosis. Dye test. That is the dye test. We are inserting methylene blue introduced into the bladder by a catheter. Dye will be seen coming through the opening. You can see whether that blue color is coming out. We are inserting into the bladder by a catheter. With the help of the catheter, we are inserting methylene blue introduced in, and we can see how, where, from which opening it is coming out. So we can see that the where is the fistula has occurred. Then 3 swab test, tampon test of Moyer, double dye test, give a patient oral phenacetin, fill the bladder with the blue tinted solution and insert a tampon. Presence of blue staining suggests vesicovaginal fistula or urethrovaginal fistula. Red staining peridium suggests uretrovaginal fistula. Metal catheter passed through the external urethral meatus into the bladder. When comes out through the fistula in the vagina, conforms PVF, the patency of the urethra. Examination under anesthesia. Midvaginal obstetric fistula, metal catheter is passed through it. You see here, can see downwards, that is one metal, that is the Sims speculum is inserted and visualizing the vagina. Then 3 swab test, by vaginal ghost test. 3 separate sponge swabs are placed into the vagina, one above the other. You see, inserted 3 swabs. The bladder is then filled with colored agents such as methylene blue. We are inserting with the help of a catheter. That is methylene blue is inserted, rubber catheter. The patient has to do some exertional maneuvers, and then swabs are removed after 10 minutes. The result of the 3 swab test: discoloration of the topmost swab, the middle swab or middle swab. Discoloration topmost swab or middle swab, we can diagnose vesicovaginal fistula. Uppermost swab setting but not discoloration. Uppermost swab is only sweating, no discoloration is there. Uretrovaginal fistula. Discoloration of the lowermost swab. But upper 2 swabs remain dry. Uretrovaginal fistula. Laboratory studies: vaginal vault fluid collection, tested of urea, creatinine and potassium. Women likelihood of diagnosis of BVF. Roll out vaginitis, urine culture and sensitivity. Biopsy fistula tract urine cytology is suspicious of malignancy. Imaging studies, radiologic studies are recommended prior to surgical repair of cervicovaginal fistula to fully assess the defect and exclude the presence of multiple fistula. Intravenous urography for the diagnosis of uretrovaginal fistula. Retrograde pyelography, intravenous Intravenous pyelography negative and high suspicion ureterovaginal fistula. Intravenous pressure is negative, not intravenous pyelography. Intravenous pressure is negative and the high suspicion ureterovaginal fistula. Cystography done in complex fistula. Sonography, fistulography for intestinal genital fistula. Then HST. Then for diagnosis of uterine fistula when patient presents with the symptoms of menorrhea. Ultrasound, CT, MRI done for evaluation of complex fistula. Then diagnostic procedures of VVF, cystoscopic examination using carbon dioxide glass, flat tried sign, combined vaginoscopy, cystoscopy, transillumination of the bladder or vagina by turning off the vaginal or bladder light allows for easier identification in difficult cases. Color Doppler ultrasonography with the contrast media of the urinary bladder bladder in cases where cystoscopic evaluation is equal. Then fistulograms indicated if conservative therapy is planned. Can see cystoscopic view of the fistula. Cystogram showing. Then prevention, obstetric fistula, primordial prevention, girls education, women's empowerment, increased age of marriage, nutritious diet in science childhood, primary prevention, availability of the family planning method services, strategy to make motherhood safer should be followed, good antenatal care, watchful progress of labor, trained birth attendants, transportation of emergency obstetric care. Prevention, secondary prevention, early recognition of CPD and prevention of obstructed labor. LSCS is indicated cases, avoidance of difficult forceps and destructive operations, prolonged catheter drainage in prolonged or obstructed labor, radiation fistula, proper dose and technique of irradiation, packing of vagina, midline block. If you suspect fistula is going to form following obstructed labor or destructive operation, insert an indwelling catheter and start continuous closed drainage. Ensure a high fluid intake. Mobilize her early, always keeping the bag below her bladder. After 7 to 10 days, examine her anterior vaginal wall in Sims position with speculum. If her bladder is still bruised or necrotic, leave her catheter in and remove only when healthy tissue is seen in the next examination. Prevention, surgical fistula, adequate exposure during surgery, minimize bleeding and hematoma formation, decision of correct planes, wide mobilization of the bladder, intraoperator retrograde filling of the bladder, cystourethroskopic during surgery. Management, conservative management, medical therapy, surgical therapy, non-surgical prevention. Conservative management, how the indications are simple fistula less than 1 cm in size, diagnosed within 7 days of index surgery, to carcinoma or radiation. Continuous bladder drainage by transurethral or suprapubic catheter, duration up to 30 days. Small fistula may resolve spontaneously. If fistula decrease in size, drainage is drainage for additional 2 to 3 weeks. If no improvement in 30 days, will need surgery. In medical management, estrogen replacement therapy, optimize tissue vascularization and healing of the postmenopausal, local estrogen vaginal cream 2 to 4 gram placed per vaginally at the bedtime for once in a 4 to 6 week. Acidification of urine to diminish risk of cystitis, bladder calculi formation, vitamin C 500 mg, orally TDS, antibiotics used, then combination of antiseptics is can read. Stis bath, barrier ointment such as zinc oxide, Vaseline application. Non-surgical intervention, electrocautery fulguration, fistula small in size, pinhole openings, vaginal and cystoscopic route that may lead to fulguration and Foley's catheter placement for 2 to 3 weeks. Fibrin glue, useful and safe for intractable fistula. Laser welding with the ND-YAG laser, fulguration and transurethral catheter for 3 weeks. Surgical management, timing repair, route, principles use. Equipment elimination, adequate exposure, patient positioning, excision of fistula tractum, then use of suitable suture material, sufficient post-operative bladder drainage. Then timing of repair. Dictum is that the best time of repair fistula is at the first closure during index surgery. Obstetric fistula 3 months following delivery. Surgical fistula recognized within 48 hours. Immediate repair. Otherwise repaired after 10 to 12 weeks. Radiation fistula after 12 months. Preoperative care, improvement of general condition, continuous bladder drainage, antibiotics, estrogen cream, topical creams for ammonical dermatitis. Preoperative assessment, local assessment of the fistula best done 1 to 3 days before the repair. Fistula status, urine routine and microscopy, urine culture and sensitivity, cystoscopy, urethroscopy, voiding cystourethrogram, intravenous urogram, retrograde pyelogram, urodynamic studies depending on cause. Route of repair then depends upon the access to the fistula site, mobility of the vagina and surgeon expertise. Site, low fistula, urethral, juxta-urethral, circumferential, loss of bladder neck, mid-vaginal fistula, high vaginal fistula, post-hysterectomy or juxta-cervical. Approach, vaginal, combined, abdominal vaginal, then transvaginal, abdominal or vaginal approach. Patient position, dorsal lithotomy position with the standard Trendelenburg position, Sims position, knee chest position, jackknife position. Instrument should be tipped and long handled. Suture material, Vectral to suture material, bladder and vaginal, polydexon on 4 meter for ureter. That is knee chest. Thus are the different types of positions. General concepts of surgery. First attempt, the best attempt, that is the which good surgery is for tension free closure, watertight closure, non-overlapping suture lines, use of interpositional grafts, use of delayed absorbable suture material, repair of VVF, vaginal approach, flash splitting method, saucerization, Latsko technique, and abdominal approach, flat splitting technique. This one, Latsko approach. See different views. Then saucerization, original Sims-Marion technique for small fistula or residual fistula after repair. Edge pairing and suturing with a silver wire. Abdominal approach indications, high inaccessible fistula, multiple fistulas, involvement of uterus or bowel, need for urethral reimplantation, complex fistula, associated pelvic pathology. Then abdominal repair, transcervical, transperitoneal, combined repair. Pedicle of interposition grafts for repair of peak fistula, post-radiation fistula, aim to support fistula repair, to fill dead space, to bring in new blood supply and area of repair. Grafts, Matthias graft, labial flattened bulbo-cavernous muscle, Gracio's omental graft, rectus abdominis, peritoneal flap graft. See these are. Then post-operative management, continuous bladder drainage 10 to 14 days, maintain output of 1000 ml per hour, antimicrobials, plenty of fluids, continuous bladder drainage, watch for any bladder block, fluid imbalance, discharge advice to pass urine frequently, avoid intercourse at least 3 months, defer pregnancy for at least 1 year. Successful repair should have abdominal delivery. If repair fails, local repair should be reattempted after 3 months. Criteria for successful repair. Criteria, good prognosis and certain prognosis. These are the measures. Okay, thank you all.